first year residents here at Wills, and it's my pleasure to present the first of today's chief rounds. I have no financial disclosures. This is a 72-year-old gentleman who presents to the Wills Eye Hospital with a plaque-like lesion on the right upper eyelid. He developed this gradual thickening of the right upper eyelid with a hard nodule over the past year. He was referred to the Wills Eye Hospital for incisional biopsy. And talking with the patient, he has no pain and endorses no vision symptoms. A little bit more about his history. He has a remote history of cataract surgery in each eye. He notably has no skin cancer history. And in terms of medications, he's on medications just for his COPD and his benign prostatic hyperplasia. He has a remote history of tobacco use. He quit smoking 50 years ago, and he has no lymphadenopathy. In terms of his exam, he's 20/20 in the right eye, 20/40 in the left eye, pinnacle to 20/30. And his pupils, his intraocular pressure, and his visual fields were unremarkable. Looking at this first clinical picture, Dr. Shields, could you comment on what you see here?
Okay, so this is an external photograph showing both eyes. We have maybe 1 millimeter right upper eyelid ptosis. There are some yellow deposits in the medial canthal region, probably xanthelasma because it's pretty symmetric. And on the right upper eyelid, we see a thickening with no erosion, no ulceration, yellow in color. And notably, there appears to be maybe minimal loss of lashes medially, but not temporally. And the globe looks intact with no redness. And I think on the left lower lid, there might be a cyst near the punctum.
Thank you. And here's a closer up picture focused on that right upper eyelid. Anything you would like to add here?
No, it seems to be involving the dermis. The epidermis seems to be intact, so it seems to be deep to the epidermis. And again, I'm concerned about the loss of lashes because then you worry about tarsal involvement of whatever this is. It'd be interesting to flip the lid. Just looking at this, I'm worried about something that's either inflammatory, gout infectious, or neoplastic.
Great, thank you. As discussed, here's the slit lamp exam. Here we see a 40 by 30 millimeter diffuse, subtly violaceous thickening of the right upper eyelid with a well-healed overlying incision. There are some medial eyelid xanthelasma on both eyes and PCIOLs that we noted in those pictures. The posterior exam here is not shown, but it was unremarkable. Dr. Shields, could you talk about what would be on your differential diagnosis at this time?
Okay, when I see eyelid lesions, want to make sure it's not inflammatory, like an autoimmune process or an inflammatory infiltration. As far as neoplastic lesions go, I would keep in my differential diagnosis basal cell carcinoma, in this case maybe morpheoform, although it's less likely for it to involve the upper lid, most likely the lower lid. I'd also keep in mind squamous cell carcinoma, sebaceous carcinoma, gout melanoma. But I have sitting on my right a plastic surgeon. I'm going to ask her.
That's a tough act to follow. I agree with what she said. Did you mention sebaceous?
Yeah.
Yes. Okay. Other things you can think of: chronic inflammation causing this. An old chalazion. That could lead to this fibrotic reaction, something to keep in mind. Other inflammatory etiologies, maybe IgG4 disease would be kind of an unusual presentation, but you may want to check that as well.
I have one other thing. I've seen sarcoid do this, where it completely infiltrates in a plaque-like lesion, but it's usually both lids or bilateral. So keep that in mind too.
Thank you both. In terms of our differential diagnosis, we centered primarily on dermal-based tumors, and given the violaceous hue of the right upper eyelid lesion, on vascular tumors in particular. We primarily focused on benign and intermediate malignancies, as well as malignant neoplasms, including hemangioma, hemangioendothelioma, and angiosarcoma. We also considered adnexal tumors, lymphoproliferative tumors. Inflammatory and infectious was a little lower on our differential, and metastatic was considered less likely, just given the slow, gradual time course of the development of that lesion on the right upper eyelid. So Dr. Mars, if this patient presented to your clinic, what would you do next?
I would probably start with an incisional biopsy first and have pathology help us out before taking a wide excision. And I would also send some labs as well, just to rule out the inflammatory conditions.
Excellent, thank you. And Dr. Shields, we have the MRI imaging here on the next slide. Could you walk us through what you see here? And we have one more slice on the next slide.
This looks like a MRI axial cut, T1 fat suppression, looks like gadolinium enhancement. And we're seeing enhancement actually of the right, and I even think the left anterior segment, involving mostly the eyelid, no deep orbital enhancement. The rectus muscles are showing, the lacrimal gland is showing enhancement both sides. Don't really see much enhancement in the rectus muscles, except maybe for the infrarectus muscle bilaterally. So it's looking like there's more enhancement on the right side involving the eyelid. Basically, this just tells you there's vascular flow to that area, maybe increased vascular flow.
Okay. Does that change your differential or modify your differential in any way?
Not really, because with inflammation, you can see gadolinium enhancement. And the fact that we're seeing it kind of bilaterally, kind of leans you a little more to something systemic, but it still could be a primary neoplasm.
Sure, that looked more enhancement temporally, whereas the clinical photos looked more like nasal involvement.
Brian, can we go back to image external photo with bilateral? Because it looked to me, when you look at the bilateral exam and compare one eye against the other, that the temporal right upper eyelid is a little bit more purplish and thickened when you compare it to the left eye.
Yeah, this is the violaceous part that
Yeah.
Dr. Cheng was mentioning.
And that would correspond to imaging somewhat as well, right?
Yeah, but there's also this flat placoid yellow portion. Yeah, when you see violaceous lesions, you also think of Kaposi sarcoma.
Now, with violaceous hue, Merkel cell typically presents as a nodule, but have you ever seen it as a diffuse process like that?
No, it's nearly always a well-circumscribed nodular lesion, the Merkel cell carcinoma, and it can involve the upper lid. That's where you typically see it. Again, super rare.
Thank you.
ไม่เห็นเซลล์เลยรอ
As Dr. Mars pointed out, the next step that we would take is to do an incisional biopsy to try to get a better picture of what is going on and what is the underlying disease process. And so that's exactly what we did. Got an incisional biopsy of the right upper eyelid, which was sent for histopathologic examination.
And what part of it did you biopsy?
Did an incisional biopsy for the
Sort of that violaceous side or the more plaque-like yellow side?
we took essentially the entire specimen, and then there was a particular focus. There was a second biopsy on the violaceous part.
And for the residents, we would take a horizontal biopsy because it's easier to close and it gives you a more cosmetic appearance rather than a vertical biopsy. So it was right along the lid crease, involving the yellow and the violaceous part.
And so next we have the histopathologic examination. Dr. Millman, could you walk us through what you see here on the slide?
So here we see the skin, epidermis, dermis adnexal unit, and you can appreciate the dermis does not look normal. There are these kind of anastomosing looking channels, irregular channels, that are not particularly filled with blood, so they kind of look more like lymphatic channels. And those are surrounded by inflammatory cells. This kind of permeative growth pattern is not typical of a benign process and would make one worry that we're dealing with low-grade vascular lymphatic malignancy. And then here you can see orbicularis muscle and adipose tissue, so there is a deeper biopsy and similar processes involving deeper structures.
So it's not as
Sinusoidal. Not as sinusoidal, perhaps a little bit more compressed, but the cells look similar. And this is where immunohistochemical stains will help us to really delineate it more. So if you go further, here is CD31, which is vascular and lymphatic marker, and we see that there are numerous vascular or lymphatic channels in the dermis, and the same process was present in deeper tissues. ERK is a more specific vascular and lymphatic marker, and it's a nuclear stain, so you can see nuclear of those cells staining. And D240 is a lymphatic endothelial marker, and again you see these anastomosing channels, which dissect through collagenous and deeper muscle and soft tissue planes. So that's not typical of a benign lesion. So when you have a tumor that co-expresses vascular and lymphatic endothelial markers and dissects through normal tissue planes, one is worried about angiosarcoma. But morphologically, these cells looked very bland, and proliferative index is very low. And that creates diagnostic challenge for us because most angiosarcomas, unless they're capaces, they tend to be high-grade lesions. And this lesion did not stain for HHV8, which typically is expressed in Kaposi's sarcoma. And it didn't stain for HHV8. And morphologically did not quite fit with Kaposi's sarcoma. So this was our impression. We actually sent it out to a soft tissue expert at NIH, and we saw it in consultation with soft tissue expert at Jefferson. And this was basically the final diagnosis on this biopsy.
Thank you, Dr. Millman. Given these biopsy results, Dr. Shields, could you talk about what your next step in management for this patient would be?
Well, angiosarcoma is very rare. Once every few years, we'll see a case of this. It tends to occur in the head and neck region, and it's usually complete surgical resection is recommended. But we have what's called a tumor board, and we meet once a month. It's plastics, ophthalmic pathology, ocular oncology, med-onc, radiation oncology. It's a whole team of about 40 people meet, Jefferson and Wills, and we discuss these cases because we get the experts and we say, how do you guys manage angiosarcoma? Do you have any chemotherapy or radiotherapy that might be useful for a case like this? But right, as of us seeing the patient, we feel it's surgical resection, but there are other alternatives that you can use. Because surgical resection would be going until you get negative margins, and that could be, a quarter of the skin on the face. So it would be very extensive resection.
Yes. As Dr. Shields mentioned, it would be an extensive process to try to resect that tumor at this time. So the decision was made at tumor board to observe. And so for the next 6 months, the patient was closely followed in the outpatient setting. An MRI was obtained at 4 months, which showed a stable decrease in that right upper eyelid enhancement. When the patient came into the office, this is the clinical picture that was taken, and the vision at that time was 20/25 in the right eye, and the exam showed no orbital or lacrimal mass, slightly thickened lid, normal position, quiet margin. Here was that MRI that was obtained at 4 months the stable decrease in the enhancement of the right upper eyelid. And then at 6 months, another MRI image was obtained. Dr. Shields, could you talk about what you see here?
Yeah, so the temporal nodule looks a little bit thicker. Always worried about, if this is true lacrimal enhancement or if that's tumor in the orbit, but it's possibly symmetric to the opposite side. So I would just be mostly worried about this temporal area.
Exactly. There was a 35 by 5 millimeter right upper eyelid enhancement that was read out on the imaging report, and it was increased since the 4-month interval imaging. Here was the clinical picture when the patient presented to the clinic for follow-up. Dr. Shields, could you talk about what you would do next here?
Yeah, so it does look a little bit thicker temporally. We still have lashes pretty much intact temporally, but absent nasally. And this fold of skin above the lid crease, that our surgery was done at the lid crease, this fold of skin is a little bit concerning too. So we could maybe discuss this at tumor board and see if we have any other therapies that could be useful, because in order to resect this, we probably have to go from the nose all the way up, maybe above the brow, all the way temporally to get clean margins, versus maybe using some chemotherapy or radiotherapy. Or we could do another biopsy and see if this has become more aggressive.
If you were to go for an excisional biopsy, would you favor an excisional biopsy with frozen margins? Would you go for a wide resection or straight to an orbital exenteration?
So we would give him that as one alternative, would be orbital exenteration. It's kind of a shame to have to do exenteration on I guess he was in his 70s, 72-year-old patient. So we would probably work with plastics and consider doing wide surgical resection with reconstruction, maybe reconstruct with supraclavicular large graft versus observation. This seems to be a slow process in an older patient.
Yeah, from pathology standpoint, these are so challenging to resect, and frozen sections, basically it's a hit or miss, because especially morphology looks so bland. So you're looking and you're saying, is this normal lymphatic channel or is it tumor? So for these types of cases, frequently what's called negative in frozen section ends up being positive in permanent sections. So these are extremely problematic.
Are there lots of mutations per megabase or small amount of mutations per megabase?
Yeah, that's a good question. I think it's dependent on what type of angiosarcoma you're dealing with. This one was not MYC amplified based on molecular testing, but I don't know if we have tumor mutational burden in this particular case. I would expect it to be high tumor mutational burden.
Checkpoint inhibitors?
Possibly, yeah.
So this is a case that we would want to send to Caris to get,
If we were considering targeted.
targeted therapy. So just for the residents, again, we send out the pathology to a company that does biomarker testing, and they also look at tumor mutational burden. That's the buzzword nowadays. So if you have high tumor mutational burden, the patient could be a candidate for checkpoint inhibitors. If you have low tumor mutational burden, then they're not likely a candidate for checkpoint inhibitors. And what's the cutoff on that? Is it 30 or 10? 10. So if you're over 10, you may be a candidate for a checkpoint inhibitor with good result. And we do this for, conjunctival melanoma, skin melanoma. And this kind of helps us to understand what patients would be good candidates for checkpoint inhibitors.
So the next step that was taken for this patient was an excisional biopsy that was again sent for histopathologic examination. And here we have the specimen that was presented to pathology. Dr. Millman, could you talk about what you see here on the slide?
Yeah, so looks similar process, perhaps a bit more aggressive with a little bit more nuclear pleomorphism and much more permeative histology. Yeah, so we had a case together in collaboration with our oncology service, perhaps 10 years prior, where it followed almost identical clinical course. Early lesion was called borderline or benign vascular neoplasm, and then recurrence looked more and more aggressive, and soft tissue experts finally rendered diagnosis of angiosarcoma, and that patient was exenterated, and the margins were positive. So I think in the eyelid especially, this highlights the challenge of diagnosis of these cases, and we need to be kind of hyper aware of this kind of bland presentation. And otherwise, everything, all other studies were similar.
Thank you.
So does the Ki-67 proliferative index correlate with tumor mutational burden?
Not really, I don't think so. Because, for example, you can have uveal melanomas, right? With, I mean, in general, in principle, no, right? You can have highly proliferative tumors that have low tumor mutational burden because they have a single genetic alteration that is a driver. So in this case, I wouldn't expect either.
So as discussed, the histopathologic examination showed the recurrence of angiosarcoma, and at the most recent follow-up, this patient is still doing well without evidence of recurrence after neoadjuvant Taxol chemotherapy, as well as excisional biopsy.
Yeah, so this was a result of tumor board. So we've discussed this case 2 or 3 times at tumor board, and one of the sarcoma experts at Jefferson said, hey, for angiosarcoma, there's evidence in the literature that giving adjuvant Taxol and even Taxol plus radiotherapy can improve the overall survival without needing to do exoneration or wide surgery. So that's what we're doing. And this is thanks to the tumor board, which meets once a month.
Thank you. And this case gives us a nice opportunity to talk about eyelid angiosarcoma. And so primary eyelid angiosarcoma is quite rare. Secondary involvement following cutaneous angiosarcoma of the forehead or the scalp is much more common, but there are fewer than 50 cases in the literature of primary eyelid angiosarcoma. These tumors tend to present as a red erythematous, violations papular or plaque-like lesion, edema of the upper eyelid, pretty similar to what our patient has here. However, it can really look quite heterogeneous in its presentation. So it can come in all different sizes and colors and shapes. So it can present as an erythematous lesion without any change in the shape, or a change in the shape, so a plaque without any change in the color. And it results in pretty frequent misdiagnosis initially. There are a couple of examples of eyelid angiosarcomas just to demonstrate the heterogeneous presentation. So this is a primary eyelid angiosarcoma that shows up as more of a basal-like appearance, more of a hemangioma appearance, more of ecchymosis, more of a metastases-esque appearance, and then more similar to ocular lymphoma. So all of these are examples of eyelid angiosarcoma and all present quite differently on clinical exam. Similar to the clinical exam being a difficult diagnosis, the histopathology is also quite difficult to conclusively diagnose. But typically what we'll see is a moderately differentiated lesion, some distinct, moderately well-formed vascular channels, atypical endothelial cells, hyperchromatic nuclei, and permeative histology, so formation of the sinusoids and collagen dissection. In terms of treatment for primary eyelid angiosarcoma, there are a couple of different options. So the first one's close observation. There's surgical resection, chemotherapy, and radiotherapy, and any combination of these above options. In terms of the literature, there was a systematic review of primary eyelid angiosarcoma and compared to chemotherapy and radiation therapy without surgical excision with or without one of those neoadjuvant adjuvant chemotherapy or radiation therapy options was associated with a decreased mortality and recurrence. So looking at the graph on the top right, In the dark black solid line, those are patients that did receive surgical excision, whereas those on the dotted line did not receive surgical excision. And so those with surgical excision had a higher rate and higher likelihood of survival event-free, so no recurrence and no mortality. In conclusion, this was a 72-year-old gentleman who presented with primary eyelid angiosarcoma, and the diagnosis can be quite difficult to make and quite challenging, both histopathologically as well as clinical exam, because it can mimic a lot of the features of other eyelid lesions, and so it's frequently misdiagnosed as cellulitis or other processes other than that. Surgical tumor resection is the gold standard in conjunction or without chemotherapy or radiation therapy. Here's some of my references, and a big thank you to Dr. Millman, Dr. Lally, Dr. Shields, Dr. Morris, and the rest of my Wills 2026 class.
Okay. Hello, everyone. My name is Mara Penny. I'm one of the PGY3 residents here, and I'll be presenting the second of two cases this morning. I have no disclosures today. Okay. So we have a 71-year-old male who presents to the emergency room for double vision and what he's describing as left peripheral vision loss for one day. He noticed the symptoms he reports when he was shaving that morning fairly suddenly, and they've been persistent since then. So a little bit more history. He has no ocular history. He has a pretty extensive medical history, including coronary artery disease. He actually had a stent placed to the LAD in 2017. Hypertension, hyperlipidemia, GERD, type 2 diabetes, history of colon cancer, status post colectomy and Volvox therapy, and then a recent diagnosis of lung cancer as well. He's on medications for the aforementioned medical conditions: aspirin, lisinopril, metoprolol, a statin, albuterol, and PPI. His social history: he has a 70-plus pack year smoking history, but no other alcohol or drug use. Family history: his mother had some hip of cancer. He's not sure what type. So eye exam. He is 20/20 in both eyes. His pupils do not have an APD. His pressures are normal. His confrontational fields are full. On extraocular motility, he has around an 80% adduction in both eyes, so a 20% deficit, and slowed saccades. His color plates are full in both eyes. And then here's his external exam. Notably, this was done at the bedside. Anterior exam only notable for mild ptosis in both eyes. Fairly symmetric. MRD 1 of 2 in the right eye and 1 in the left eye. Also with significant cataracts. And then his posterior exam is normal, notable for a choroidal lesion along the superior arcade in the right eye. So, just to summarize what I just mentioned, we have a 71-year-old male with an extensive past medical history, including malignancy and multiple vascular risk factors, who's presenting with diplopia and subjective left visual field loss. His vision is 20/20, he has no APD, his color plates are full, and his confrontational fields are full. His EOMs are notable for mild adduction deficit in both eyes and symmetric ptosis. So given this information, Dr. Surgat, at this point, what are you thinking is on your differential, and what would your next steps be?
So I think you concentrate on the double vision first. And what kind of lung carcinoma does he have? Small cell?
Non-small cell.
Non-small cell. And is treatment for that?
He is on immune checkpoint inhibitor. He started recently.
So, I think, you know, you
ไม่ดีนะ
have bilateral adduction deficits, so you're going to think,
เขาบอก
starting anteriorly, could it be neuromuscular junction? It's always possible.
MG ได้ไหม
That's not emergent because
Summary.
he doesn't have any other bulbar signs. He has no orbital findings, unlikely cavernous sinus here. Going back along the nerve fascicle, clivus, nothing there. But now we started to talk about midbrain.
midbrain
So adduction deficits,
collagen ไม่
there may
ได้
be some upgaze involvement, but not always. We're thinking midbrain. So I think you do an MRI here with and without gadolinium, looking at that area, see if there's a bleed, stroke, something in that region. So that's where I would go first because that's something that would require more prompt intervention. Leaving the visual field stuff off for now until we learn some more about that.
Okay. So notably, this patient was seen at an outside hospital at this point and was not yet under our care. A little bit of further history. 1 month prior to presentation, he was diagnosed with metastatic lung adenocarcinoma, which we kind of got into. And then 1 week prior to presentation, he presented to an outside ED with chest pain, shortness of breath, and was actually admitted for an NSTEMI and discharged on DAPT. And then on review of systems at presentation, he is positive also for chest pain, shortness of breath, difficulty swallowing, word finding difficulties, imbalance, double vision, eyelid drooping, and that peripheral vision loss in his left eye.
ไมเลอร์เนี่ย
Given this additional review of systems information and sort of recent medical history, does that change your thought process here at all and what you'd like to do first?
Well, again, this man now has things that, you know, where he's potentially acutely very ill. So I think this changes immediately from outpatient to inpatient. Scanning is still first. The word finding problems and all certainly can be cortical in nature. So we need imaging of the brain and base of the skull.
เน็ตมันหลุดอ่ะเนี่ยอยากรู้ว่าเคสนี้เป็นยังไง
นี่เนี่ยมันจะมาเมื่อไหร่
ไม่รู้อะไร
เมื่อก็เชื่อมโทรศัพท์ไปก่อนดิ
Welcome to the webinar. You have entered as an attendee in listen-only mode.
So they did also consult GI, and they did an esophagram